Hello, everyone.
Hello, everyone.
Um, Please mute yourselves because otherwise we will have overlap of sounds. I'm Jens Manton Garcia, the current chair of EFISC, the Fungal Infection Study Group from ESCMID, and together with Helmi bin Sulaiman and his group, we are organizing this webinar. It's the second time we organize it together, and it's actually really a pleasure to do it again. This time we are speaking about invasive aspergillosis, and we will make a comparison how the same infection is treated in two different settings, one in the east, the other one in the west. Yeah, I mean, like we have some lovely and magnificent chairs and also three speakers. And you can type your questions any moment in the chat. They will be answered all together at the end of the session. Each of the speakers will have 20 minutes. So it's like around 60 minutes of presentations and then, as mentioned, a shared discussion. So, Helmi, thank you very much again.
Thanks, John. Hi, thank you. I'm representing MMIG, the Malaysian MSADC Malaysian Mycology Group. Um, I think we have a problem in terms of the moderator of the day, so I can actually go ahead and introduce our first speaker after this. And for the Malaysians joining us today, I will actually be sharing the link after this for the registration so that you can get the CPD points after the event. Yeah. Can I go ahead with introducing the first speaker, John?
Yes, please.
Okay. Hi, everyone. So I'll be presenting the first speaker today who will be giving tuberculosis. Our first speaker is Dr. Chua, who is a colleague of mine from Malaysia. He will be presenting, as I said, the general overview of invasive aspergillosis, and he is currently in Australia for his attachment. Dr. Chua, the floor is yours.
Okay, thank you so much, Dr. Hilmi, for that kind introduction. So I will start off by sharing my slides. If everyone could let me know if you could see my slides well.
Yes, we can see everything properly.
Okay,
Thank you.
perfect. So without further ado, I'll then kickstart the webinar today on invasive aspergillosis. For my presentation, I will start off with the global burden and mortality of invasive aspergillosis before giving some brief overview on the pathogenesis and how actually the at-risk population for invasive aspergillosis has evolved over time. Then I will move on to the clinical manifestation and the current diagnostic approach before concluding my slides with the emerging challenge of azo-resistant Aspergillus fumigatus. So invasive fungal disease has increasingly recognized as a global health threat. And the recent global estimates suggest that more than 6.5 billion people are actually affected by a life-threatening fungal disease. And invasive aspergillosis account for a substantial portion of this total burden, approximately 1/3 of the total incidence. And the increase in incidence is likely due to a better recognition, especially among the ICU and the COPD patient, which invasive aspergillosis was previously under-recognized. And invasive aspergillosis also has a very high mortality burden. The same global estimate shows that nearly half of the total crude mortality were attributed to invasive aspergillosis among the severe fungal disease. And across patient group with invasive aspergillosis, mortality rate is extremely high even though they are treated. And one of the reasons could be due to delayed recognition, where invasive aspergillosis clinical presentation sometimes could be fairly non-specific and they could mimic causes such as viral or bacterial pneumonia and even COPD exacerbation, then subsequently leading to delayed antifungal initiation. And reflection of high global burden, high mortality rate, and together with also limited antifungal options and also emergence of azo resistance, This actually leads to WHO to list the Aspergillus fumigatus under the critical group for the fungal priority pathogen list in 2022. So Aspergillus is actually a ubiquitous environmental mold that was commonly found in soil and decaying vegetation. And because inhalation exposure is so common, having a positive culture for Aspergillus without a proper clinical context actually signifies either environmental contamination or airway colonization rather than a true invasive disease. And with recent molecular advancement techniques, more than 350 species has been described. And among these, Aspergillus fumigatus is the most common pathogen that causes human disease, followed by Aspergillus flavus and Aspergillus terras. Some reason why Aspergillus fumigatus is particularly successful as a human pathogen could be due to the small conidal size that allows deeper penetration into the lower respiratory tract. It also thrives very well on body temperature, and it does have some mechanism to allow it to evade the innate human mechanism. And there's also some geographical variation where Aspergillus flavus is actually the most prominent species among tropical and arid regions. So, regards to the pathogenesis of invasive aspergillosis, the infection always starts with inhalation of the spore to the lower respiratory tract. However, in the immunocompetent patient, the alveolar macrophages and neutrophil efficiently clear off this inhaled conidia. However, in the patient that's immunocompromised, either due to neutropenia or impaired immune response, either on intensive immunosuppressant therapy or cortical exposure, this actually allows germination of the spore to invasive hyphae, which then leads to angioinvasion and systemic dissemination of the disease to other parts of the body organs. And aspergillosis has a broad spectrum of disease, mainly determined by the host immunity. In a host with a normal immunity but abnormal lung architecture, the colonization of the Aspergillus species could actually lead to, in a pre-existing cavity, can cause chronic disease that leads to aspergilloma. And in patients with the immune hyperactivity, such as in asthma or cystic fibrosis, the Aspergillus antigen could actually trigger allergic response and leads to conditions such as allergic bronchopulmonary aspergillosis. And patient in immunodeficiency, as previously mentioned, it can cause invasive disease. And this slide shows the landscape of patients at risk for invasive aspergillosis has actually evolved over time. Historically, invasive aspergillosis were commonly found in profound neutropenic patients, such as in leukemic patients and transplant patients. And in years, it's broadened to include lymphoid malignancy and patients in biologics. Now, over time, invasive aspergillosis has increasingly recognized in a non-neutropenic host, especially in the ICU population that has severe viral pneumonia caused by influenza and COVID-19. And with modern hematology therapy, such as small molecular kinase inhibitor or CAR T-cell therapy, is currently also recognized as a common association to with this group of patients to have invasive aspergillosis, although they are not profound neutropenic. And the key message is that invasive aspergillosis now affects a much broader and more heterogeneous patient population. And this table actually summarizes the major host group at risk for invasive aspergillosis. And among all these groups, hematology and stem cell transplant patient remains the classical high-risk group for invasive aspergillosis. And the main key risk factors could be driven by prolonged neutropenia, prolonged use of corticosteroids, if they are having graft versus host disease, or on T-cell and B-cell suppressive therapy. In the solid organ transplant group, the risk is actually organ specific, where the lung and heart transplant patient actually has the highest incidence of invasive aspergillosis. And common risk factor could be due to colonization with aspergillosis species, post-transplant CMV infection, having rejection requiring augmented immune suppression. And in the last group, which is the critically ill group that is non-neutropenic, The common risk is normally not driven by neutropenia, but more towards abnormality in the local airway defenses. And this could be due to viral-induced epithelial injury, or if there's immune dysregulation during the critical illness, and also exposure to corticosteroid use. Just an overview regarding the clinical manifestation of invasive aspergillosis. Pulmonary manifestations is the most common clinical manifestation. As we previously mentioned, infection normally occurs through the inhaled chlamydia. And even though pulmonary aspergillosis is the most common manifestation, the symptoms are actually fairly non-specific that could range from just having some fever, chest pain, shortness of breath, cough, and with or without hemostasis. And it could be even asymptomatic in the neutropenic patient. Pulmonary aspergillosis can be broadly divided into two groups. It can either be an angioinvasive disease, which is commonly seen in the neutropenic group, when there's the invasion of the pulmonary vessels subsequently leads to thrombosis, infarction, and pulmonary necrosis. Or it can also be classified under airway invasive disease, where the fungal hyphae actually invade the basement membrane of the respiratory tract, and they could manifest as tracheal bronchitis or bronchopneumonia. And this is commonly seen in a non-neutropenic host with influenza or COVID-19. So when we are suspecting pulmonary invasive aspergillosis, the imaging of choice will be a non-contrast high-resolution CT thorax. And in a classical neutropenic patient, the main CT features will be pulmonary nodules with surrounding ground glass opacities, which also commonly known as halo sign. And normally this reflects of infected nodules surrounded by hemorrhages. And in time with neutrophil recovery, it actually develops into cavitations and display this typical air crescent sign. However, in non-neutropenic hosts, such as in influenza and COVID-19, the CT manifestation could actually be non-specific, as they could present with either just patchy consolidation or just ground glass opacities without nodules. And it's generally not recommended to actually repeat the imaging too early or before 14 days, as early imaging could actually give a false impression of failure of therapy due to the wide hepatization of the disease during the early course. In regards to invasive rhinosinusitis, patients could normally present with nasal congestion or facial pain. And if there's involvement of the orbit, they could also come with blurring visual disturbances. And CT and MRI sinus imaging normally will show a soft tissue invasion with bony erosion as well. For CNS aspergillosis, they could occur either due to secondary hematogenous dissemination or commonly due to a direct extension of the invasive sinus disease. And common presentation could be either a headache or focal neurological deficit when there's cranial nerve involvement. And brain imaging normally shows some brain-enhancing lesion. But it's important to note that CNS aspergillosis is actually attributed to the highest mortality among all the invasive aspergillosis syndrome. For the less common symptoms, clinical manifestation of aspergillosis could be endocarditis, where it's commonly associated with patients with, commonly found in patients with prosthetic heart valve. For ocular aspergillosis, patients may present with keratitis, periorbital cellulitis, or endophthalmitis. And for cutaneous aspergillosis, they may present with a non-healing skin ulcer or necrotic nodules, which then can be diagnosed with a skin biopsy. Moving on to diagnosing of invasive aspergillosis, histopathology and culture remain central in the diagnostic approach. In order to diagnose a proven invasive aspergillosis, the histopathology requires demonstration of the fungal hyphae invading the tissue and or blood vessels. And the typical morphology of aspergillus under the microscopy is they will look like a septated hyphae with the 45 angle degree branching. However, this morphology alone is non-specific. And culture should always be attempted should be always be sent, even though it's less sensitive. But however, if there's a positive culture in the right host and clinical context, actually strengthen the likelihood of and the diagnosis of invasive aspergillosis. And importantly, if there's a positive culture, it also allows species identification and also allows us to perform antifungal susceptibility, which is becoming more prevalent in the events of emerging azole resistance. And also there's presence of cryptic aspergillus species that actually have a very varying antifungal susceptibility. Moving on to the non-culture-based assays, which are actually good tools as they are very good tool as they are rapid and more sensitive compared to culture. And the most established biomarker for aspergillosis is actually galactomannan assay. And it actually detects the galactomannan, which is a cell wall polysaccharides that release during the active growth of the fungal. And it can be detected in serum and bronchoalveolar lavage fluid. Serum galactomannan is particularly useful in the screening in neutropenic hematological patients that are not on mold prophylaxis. However, in order to diagnose pulmonary disease, the bronchoalveolar lavage galactomannan is actually more sensitive compared to the serum galactomannan. In regards to 1,3-beta-D-glucan assay, it's actually a very broad spectrum fungal marker that detects the beta-D-glucan, which is a component of the cell wall that presents in many species of the fungi, such as Candida, Pneumocystis, and it's not specific to Aspergillus. So the use of this test as a standalone test is actually very limited and is always required to use in combination with other tests such as the galactomannan or PCR. And in regards to Aspergillus PCR, Aspergillus PCR can be applied to serum, bronchoalveolar lavage fluid, and also tissue to increase the diagnostic confidence, especially when they integrated together with the galactomannan assays. However, it's also known that not all the lab actually have this Aspergillus PCR assays available. It's not widely available in most settings. And the key point for this is that even though this non-culture based assay is useful, it should never be used in isolation. And it is best to actually use in combination and integrating the clinical assessment and also imaging while we are trying to diagnose a case of invasive aspergillosis. So this is the 2020 EORTC MSGERC consensus criteria that's commonly used to define a case of invasive aspergillosis. The criteria requires the integration of 3 domains. It's a host factor, clinical criteria, and mycological criteria. So if there's a host factor and a compatible imaging, but no mycological confirmation, it then classified as a possible disease. And with the addition of mycological evidence, it then becomes a probable disease, probable invasive pulmonary aspergillosis, and a proven invasive aspergillosis will require the positive histology showing the tissue invasion by the fungal hyphae as previously mentioned. And it's important to note that this EORTC MSGRC consensus criteria is primarily designed for classical high-risk immunocompromised patient. And it is less applicable to ICU population with invasive aspergillosis, as this group of ICU patients do not normally have the traditional host factor as previously mentioned. Therefore, it's very important to have an ICU-specific framework in order to improve recognition of invasive aspergillosis among this group of patients that has high mortality. I think so. Modified Aspergillus ICU was developed in 2021, mainly is to distinguish between colonization and also probable invasive aspergillosis when there's presence of a positive Aspergillus culture from the lower respiratory tract, and they also integrate clinical criteria that's more relevant in ICU settings, such as respiratory deterioration, compatible imaging, and also fungal biomarker to further improve recognition of invasive aspergillosis among this non-neutropenic ICU patient. And then more recently, Fund ICU 2024 provide a broader ICU adapted framework where they actually incorporate ICU-related risks such as COVID-19, influenza, solid tumor, uncontrolled HIV infection, or decompensated liver failure and moderate or severe COPD into the whole framework to improve the diagnosis of a probable invasive aspergillosis. So with this broad ICU consensus definition, it improves recognition of invasive aspergillosis among this ICU population. So in regards to azole-resistant Aspergillus fumigatus, it's actually an emerging global concern. The resistance rates varies among globally, where Netherlands and certain part of Europe actually has the highest incidence. The azole resistance is commonly linked to the CYP51A mutation, and importantly, it's been shown that this resistant strain is found in azole-naive patients and even on environmental sampling, which supports the likelihood of environmental acquisition. And Netherlands illustrate this well as due to its intensive azole use as a fungicidal in their agriculture, it actually creates the environmental hotspot for resistant strain, which can be found in the flower bulb waste. And also, multiple studies has also found that resistant aspergillosis were detected in the tulip bulb that were commonly exported to around the world and cause a concerns for international spread of this azole-resistant aspergillus species. And from a clinical perspective, this is very important because azole resistance can compromise the first-line therapy, azole therapy, and it's always linked with a worse outcome. And this also highlights the growing importance of having a ongoing local resistance surveillance culture and also consider susceptibility testing in this positive culture, especially when we're dealing with breakthrough infection or treatment failure. So the key take-home message or the final slide that I have today will be invasive aspergillosis carries a high morbidity and mortality. The landscape has evolved and the risks have expanded beyond the classical neutropenic host. Due to the inhalation of the Candida, pulmonary disease predominates, but the presentation is often non-specific and may lead to delayed diagnosis. The diagnosis require integration of post-risk imaging and mycology in order to better diagnose invasive aspergillosis. And currently, emergence of azole resistance makes culture and susceptibility testing actually increasingly important in these times. Thank you so much for your attention.
Thank you very much for this excellent presentation, Dr. Chua.
Thank you.
Good afternoon, everyone. I apologize for the delay. And welcome to today's webinar, Invasive Aspergillosis Bridging Perspective from Asia and Europe, organized in collaboration with ESCMID Fungal Infection Study Group and the Malaysian Society of Infectious Diseases and Chemotherapy Mycology Interest Group. My name is Yasemin Çağ from Istanbul Medeniyet University, Turkey. It's a great pleasure to be here with you today, and thank you all very much for joining us. Today, I will be moderating the session together with Dr. Shalini Devigunasegaran, clinical microbiologist at Hospital Tuanku Jafar, Malaysia. It's a great pleasure to co-chair the session with her. And invasive aspergillosis remains a major challenge in clinical practice, particularly among immunocompromised and critically ill patients due to its high morbidity and mortality. It requires timely diagnosis, multidisciplinary collaboration, and continuously evolving management strategies. We are very pleased to bring together colleagues and experts from different parts of the world to share their experiences and perspective on this important topic. And I would like to hand over Dr. Shalini, my co-chair. Dr. Shalini.
Thank you very much, Prof. Yasemin, for the very kind introduction. Indeed, it's a pleasure to be part of this collaborative webinar between MMIG and EFISG. Just a kind reminder and a quick housekeeping note on the
Dr.
certification.
Shalini, we couldn't see you.
Okay, John has to enable me. Camera, I'm unable to switch on the camera. Okay, so for participants from Malaysia, kindly fill in the certificate link or scan the QR code that will also be provided at the end of the webinar. Please remember that there will be no CPD points awarded for this webinar, so you have to fill the link later on. Okay. All right. So our next speaker for today is Assistant Professor Dr. Umu Afira Zainul Abid from Kuliah of Medicine, International Islamic University, Malaysia. Dr. Umu Afira completed her Masters in Medicine, in Internal Medicine, and subsequently pursued a clinical fellowship in infectious disease at University Kebangsaan, Malaysia. Her academic and research interests span infectious diseases, molecular diagnostics, antimicrobial resistance, genomics, and emerging infections. She has also been actively involved in numerous national and international research collaborations as well, and has publications in peer-reviewed journals, including PLOS1, Nature Genetics, etc. In addition to her academic contributions, she's also actively engaged in postgraduate teaching, supervision, and international scientific presentation, including ESCMID Global and APCCMI conferences. Today, she'll be presenting a case-based discussion of invasive aspergillosis. Dr. Umu Afira, the virtual stage is yours.
Thank you, Dr. Shalini. Hi, everyone. I'm Afira from, actually, I'm from Malaysia. So this is my country. So it's a small country with 36 million population. So about my country, there's a bit of introduction. So we have West Malaysia and East Malaysia. So I work in the largest state of Peninsular Malaysia, which is Pahang. So there are lots of beach and waterfalls. So please come and visit us in Malaysia. About the case that I'm going to present today is actually I'm going to reminisce my old memories back when I did my fellowship. So I did my fellowship at Kuala Lumpur. So this is the Hospital Chancellor Tuanku Chris. It is located in Cheras, Kuala Lumpur. It is a distinguished teaching facility, university hospital with 1,000 plus active patient beds. Let's zoom in. It's actually the incidents that the case that I'm going to present is actually occurred in burn unit. So the burn unit located on the 5th floor. It comprises the 4 ICU room, 2 isolation room, hydrotherapy room, and treatment room. So my case, the patients that I saw is actually admitted to isolation room 2. But this patient, he is a 31-year-old gentleman. He was diagnosed with epilepsy, untreated, and was not on any proper follow-up. He drove himself to the hospital at day 3 of illness. So what happens to him? He actually alleged a scalding burn injury while boiling water for ketum preparation. So a note to all our colleagues today. So what is ketum? It is known internationally as kratom. So how to pronounce it is actually like reading the herbology in Harry Potter books. So Mitragina speciosa. So it's a tropical tree native to Southeast Asia. So it has a dual pharmacology. In low doses, it acts like a stimulant, and it can act like an opioid when given in a high dose. And then how they prepare the ketum is actually the leaves boiled in water and then consumed as tea. So why it matters to this case? Because the combination of untreated epilepsy and the traditional substance use is important respective for burn injuries in this patient. So he sustained actually a very devastating thermal injury. So he sustained a total about 45% major burn injury of total body surface area. So when you have more than 20% injury, so it considers as a major burn injury. So this is how he when he was admitted to burn unit. So he sustained injury that involved his left face, and then right upper limb, left lower limb, and also anterior chest, lateral body, and also thigh. And then about this patient also, about his lower limb, he actually sustained compartment syndrome. So what they did actually in burn unit, they do the tangential excision. So it's a surgical removal of the burn eschar in thin sequential layers. So the excision continues until punctate bleeding from the viable dermis is reached, indicating healthy tissue. So the main focus is actually lateral aspect of the left chest. And then what they do is they applied allograft. So allograft is actually a temporary skin graft from a screen disease human donor. So this repeated tangential excision is actually for wound bed preparation. So about the left upper limb, he developed a complication, compartment syndrome. So they have to proceed with escharotomy. So about escharotomy is an emergency surgical procedure performed for severe deep circumferential burns. It involves by making incision through the tough and dense burn tissue. The intention is actually to relieve the pressure caused by swelling beneath the burnt skin and to restore the blood circulation to the affected area. So this is another image from public domain online resources. So you can see how they do the escharotomy. Unfortunately for this young gentleman, he had to undergo left transhumeral amputation because there is a severe necrosis from shoulder to distal arm, and they have to actually do the brachial artery ligation, which myodesis. So what is myodesis? Is when they actually, the muscle stitch onto the arm bone, so the stump is stronger and move better. So when actually ID team involved in this case is actually at day 14 of the patient's admissions to burn unit. So they call in because something white appeared on the wounds. So this is the wound. So you can see this is the allograft area. So this a white patch, and this visible white spores-like lesion actually quite a lot, and then you can see there is also evidence of infiltration to the underlying muscle. So what we did back then is actually we sent multiple tissue culture and also histopathology and the skin actually for the histopathology examination. So about the culture, the colonies actually on the potato dextrose agar, we can see a smoky grey-green with a slight yellow rivers. So it was described that this is a typical features of Aspergillus fumigatus, and some isolates may display a lavender diffusible pigment, and those very mature colonies can turn into slate grey. And this Aspergillus is usually a rapid growth organism. And then about we also did actually our microbiologists help with the lactophenol cotton blue stain. So it demonstrates the diagnostic microscopy features of Aspergillus fumigatus, like what our first speaker mentioned just now. So the branching is like 45 degrees, and then it was described as a typical of Aspergillus fumigatus. So this image is a courtesy from Dr. Salina from Institute Medical Research Malaysia. So you can see this is a fungal Aspergillus fumigatus. So you can see the conical shape terminal vesicles. There is a smooth wall coniodophores and single row of halides. Okay. So the culture is actually confirmed to be Aspergillus fumigatus. And then now we go through we go to the second part, which is the histological examination. So this is actually H&E staining. So let me zoom in. So you can see this is the fibrocollagenous area, and then there is a bit of a necrotic part, and this is actually the area where we can see the fungal elements. So you can see there is actually 45 degrees branching, and it looks septated. And this is also a fungal elements. So next is actually GMS staining. So it highlights the polysaccharides within the microbial cell wall. So usually the fungal elements appear black in microscopy. So this is actually the fungal body in this case. Sorry. So about reading the hyphae, so usually you have the differential is between mucor and aspergillosis. So like what Dr. Chua mentioned just now, aspergillus is usually you can actually remember the mnemonic of A. It's like 45 degrees. So it has a branching of 45 degrees. And then about mucor is actually usually they tell me is around 90 degrees branching. And then it has like a balloon, a ribbon like hyphae. So you can see it's like pad area here, and they describe it as ribbon like hyphae. And about this aspergillus is actually quite uniform hyphae, so it's quite regular. And then you can see the aspergillus have septated, but this one accepted. So they don't have any septate area. Okay, so the histology also showed you infiltrative fungal organism which branching hyphae. And then we also send galactomannan. So the first initial galactomannan is 2.76, and within 6 days it's actually escalated to 4.2. So it's also positive. So based on the diagnostic criteria, this is a proven invasive fungal disease because you have a clinical, you have a culture, histological, and also serology to support your diagnosis. In terms of galactomannan and compare with the beta-glucan, I think the first speaker already addressed it. So galactomannan was more specific to aspergillus. So we use galactomannan in this case. And then how we approach in terms of therapeutic. So so the surgeon actually help with aggressive debridement for the source control part. So he did actually split thickness skin graft. It's a surgical procedure to cover the open wound of the surgical defect. So they harvest the normal skin, and they actually will prepare the wound bed and apply this harvested skin. And then in terms of systemic therapy, this patient received voriconazole for duration of 2 weeks. And the reason why we choose voriconazole is actually based on old evidence in 2002 that in terms of voriconazole have a better outcome and better survival compared to amphotericin. And I think the next speaker maybe can address on the isavuconazole. And in terms of topical also, the surgeon helped with the application of silver sulfadiazine topical to help local antifungal coverage and reduce the wound burden. At 36 hours, so noted there is a substantial reduction in visible spores, systemic inflammation improving, galactomannan trending also negative, and the surveillance cultures also negative. So about the infection prevention control, because we have a problem why this man actually contracted aspergillus in burn unit. So is it nosocomial? That is the questions that we had back then. So we do a comprehensive, like a proper standard precaution, contact precaution, airborne precaution. And we tried actually to investigate by doing, like look for any loophole. So however, we couldn't find any explanation in terms of potential nosocomial source for this gentleman. And the air sampling result is negative. The room infrastructure is actually intact. There is no other cases that have aspergillus infection. And during 3 months follow-up, there is no outbreak as well. So we postulate maybe the high likelihood this patient have a community acquired because of maybe tropical climate in Malaysia, which is high ambient phosphor counts. And then the wound also when the patient is already presented at day 3 of illness. And then he is also immunocompromised with the burn injury that can induce the immune collapse, and the spore biology that is small enough to be inhaled or absorbed through wounds. So for takeaways for the practice for our practice, we need to suspect early. So in burn patient or graft in immunocompromised patient, suspect fungal. So you need to have a comprehensive assessment in terms of clinical, culture, histopathology, and also use your serum galactomannan and any other investigation to support you. Sometimes together you can confirm the diagnosis, and you need to treat aggressively. So as we most of ID physician, we always say about source control. So we need to be aggressive in terms of that, because these biofilms thrive on the vitalized tissue, and we need to think about the geographical part as well. And this is the patient a few days prior to his discharge, and I would like to thank my teachers and colleagues in helping me with this case presentation. Thank you.
Thank you for this interesting case and for this excellent presentation, Dr. Ümmü. It's now my pleasure to introduce our third speaker, Dr. Marina Machado from Hospital General Universitario Gregoria Marañón in Madrid, Spain. Dr. Marina is a specialist in infectious diseases with extensive clinical and research experience in the management of invasive fungal infections and infections in immunocompromised patients, including transplant recipients and oncohematological patients. She has contributed to more than 50 scientific publications and is actively involved in several national and international clinical studies and trials. Today, she will be sharing the European perspective on management of invasive aspergillosis. Dr. Marina, over to you.
Thank you so much for your kind introduction. I will share my presentation. So, why invasive aspergillosis is still matters in this field in Europe? Because of the mortality associated with this disease remains unacceptably high. We reported overall mortality rates ranging from 40% to 75%, and particularly elevated among critically ill patients and immunosuppressed presenting with disseminated disease. Aspergillosis is no longer, as previously said, restricted to the classical hematological patient population, as its epidemiological profile has expanded in recent years. Also, the emergence of antifungal resistance, the widespread of use of immunomodulatory and targeted therapies, the recognition of ICU associated aspergillosis, and the growing incidence of breakthrough fungal infections represent significant challenges for diagnosis, management, and of course, patient outcomes. Traditionally, invasive aspergillosis has been associated with a well-defined population of classical high-risk hosts, particularly patients with acute myeloid leukemia, recipients of allogeneic hematopoietic stem cell transplantation, and individuals, as you know, with prolonged neutropenia. However, the epidemiology of aspergillosis has changed. Emerging host population now included solid organ transplant recipients, critically ill patients, individuals with severe influenza or COVID-19 infections, patients receiving CAR T-cell and other novel hematology treatments, as well as those also exposed to corticosteroid or biological agents. From a European perspective, the increasing use of targeted immunosuppressive therapies has further expanded at a risk population, contribute to a rise in cases of non-neutropenic aspergillosis. These shifts highlight the changing landscape of aspergillosis and emphasize the need for greater awareness, improved diagnostic strategies and methods, and adaptation of current clinical approaches. An additional challenge in the management of aspergillosis is the increasing emergence of antifungal resistance, particularly azole-resistant in Aspergillus fumigatus. Resistance has become a growing global concern with geographic variabilities, suggesting important environmental and clinical drivers. The European epidemiology of invasive aspergillosis and azole resistance is far from homogeneous. Higher rates of azole resistance have been reported in specific countries, particularly the Netherlands, the United Kingdom, and Germany, as you say in this figure. The field pop in Spain, data from the field pop and the Aspen studies reported azole resistant rates ranging from 1.2% to 5.5% in Aspergillus fumigatus isolates. Although this percentage may appear relatively low, even modest increases in resistance have significant clinical implications, as they may compromise first-line antifungal therapies, delay appropriate treatment, and negatively affect patient outcomes. Environmental fungi are exposed to broad-spectrum antifungals that are also used as first-line treatments in clinical practice. Ecological niches may act as amplifier of resistant genotypes, and one example is the storage of green waste and compost. There are multiple extrinsic factors expected to influence the incidence of antifungal resistance, and these include changes in pattern fungicide use, in the environment and in waste management, change in at-risk host population, or climate change as natural disaster also occurs and probably affect this route of moving spores from one side to another. Two main routes contribute to the development of azole resistance in Aspergillus fumigatus: patient-acquired resistance associated with prolonged azole therapy, and environmental resistance driven by exposure to azole fungicides. And of course, increasing evidence suggests that environmental exposure may induce cross-resistance to medical azoles. The most common resistance mechanisms involve CYP51A gene alterations, particularly promote tandem repeat mutation, combined with point mutation such as TR34 or TR46. These mutations are widely identified in environmental and clinical isolates worldwide, including azole-naive patients, supporting the hypothesis that environmental fungicide exposure plays a major role in the emergence and spread of azole resistance. An additional emerging challenge in invasive aspergillosis is the recognition of cryptic aspergillus and non-fumigatus species, which have been associated with particularly poor clinical outcomes and mortality rates approaching 90% in some reports. These species are frequently underdiagnosed because conventional microbiological methods often fail to differentiate them, making molecular approach such as DNA sequencing increasingly important, but not widely available in some specific institutions. Cryptic species may exhibit reduced susceptibility or intrinsic antifungal resistance, occasionally through mechanisms that remain uncompletely understood nowadays. Within the Aspergillus fumigatus complex, Aspergillus lentulus represents the most frequently identified cryptic species. Although it accounts for less than 3% of clinical Aspergillus fumigatus isolates, studies suggest that approximately 30% of azole-resistant isolate may be misidentified or inadequately categorized. These species also have been implicated in breakthrough infection, particularly among hematological patients, solid organ transplant recipients, and individuals receiving prolonged corticosteroid therapy. This was a prospective multicenter cohort study conducted across 13 Spanish university hospitals. And you can see all the breakthrough invasive fungal infection among adult patients with hematological malignancy. As you can see, aspergillosis cases were produced mainly due to non-Aspergillus fumigatus species. And as this study reflects the high mortality of this patient is particularly an issue. Clinically relevant differences exist among Aspergillus species. These differences are clinically relevant because they may influence diagnostic performance, empirical treatment selection, and overall patient management. And accurate species identification and susceptibility testing are increasingly important for optimizing antifungal therapy. The epidemiology of invasive aspergillosis in intensive care units also has undergone an important paradigm shift over recent years. These figures reflect data from our hospital of main underlying disease in aspergillosis cases between two periods, one period pre-pandemic and the second period post-pandemic situation. Between 2014 and 2019, aspergillosis was predominantly associated with patients with hematological malignancies, while critically ICU patients represent only a small proportion of cases, less than 5%. But during the period from 2020 and 2023, a marked increase in aspergillosis among ICU patients was observed in our study, rising from nearly 30% of the cases. This change is likely related to the emergence of viral-associated pulmonary aspergillosis, particularly in the context of severe COVID-19 and influenza. This trend toward an increasing number of cases in patients non-classical considered immunosuppressed demonstrate that the classical ERTC guideline definitions at that time have become outdated. It became necessary to reconsider and develop new definitions in order to conduct observational studies that will also include other populations at risk and not represented with the classical risk factors. The recognition of viral-associated pulmonary aspergillosis has led to the development of a specific diagnostic definition for critically ill patients. Initially, influenza-associated pulmonary aspergillosis criteria were proposed to address the limitation of conventional definitions in this setting. During the COVID-19 pandemic, the ECMM introduced criteria for COVID-19 associated pulmonary aspergillosis, incorporating clinical bronchoscopic results and mycological findings. This definition recognizes that critically ill patients frequently differ from classical hematological population and clinical presentation, and may present with distinct clinical profile, including invasive aspergillosis, tracheobronchitis. The incidence of influenza pulmonary aspergillosis varies across Europe, ranging from 1% to 20%. Important intercenter and regional differences exist, partially related to study design, patient characteristics, and diagnostic approaches. A similar situation has been described in COVID-19 associated pulmonary aspergillosis, or CAPA, where variability appears even greater and incidence rates changing through the pandemic, likely reflecting differences in diagnostics approaches and, of course, clinical practices of the institution. The variability observed in IAPA and CAPA incidence rates across regions suggests that geographic factors may play an important role in disease epidemiology. On one hand, intrinsic factors related to aspergillosis itself, including environmental burden and strain-specific virulence characteristics, may contribute to regional variability. On the other hand, host-related factors are also highly relevant, including genetic background, vaccination coverage, and differences in healthcare system, such as access to intensive care resources, chemotherapy, transplantation programs, or advanced medical interventions. Beyond these geographic variabilities, several non-geographical factors influence the reported incidence of IAPA and kappa. Studies including a higher proportion of bronchoalveolar lavage sampling to report increasing incidence rates, likely due to improved diagnostic sensitivity. Similarly, the use of fungal biomarkers and molecular methods, such as galactomannan and PCR, is associated with higher detection rates. Also, study design contributes to variability, as prospective studies frequently report higher incidence than retrospective analysis. The application of classified of IAPA and kappa diagnostic criteria may increase case identification compared with conventional definition of ERRTC. Patient-related factors are also relevant, as a study restricted to mechanically ventilated or more critically ill population often describe higher incidence rates. Local treatment practices, particularly the use of corticosteroids or immunomodulatory agents, may also influence the risk of development of viral-associated pulmonary aspergillosis. Despite major advance in the field, early diagnosis of invasive aspergillosis remains a significant challenge across Europe. Several factors contribute to this difficulty, including variability in the implementation and interpretation of fungal biomarkers, and unequal access to diagnostic resources. Rapid diagnostic methods are getting increasing importance, particularly in resource-limited settings, where timely identification may improve clinical decision-making and patient outcomes. In addition, antifungal susceptibility testing remains unavailable in many centers, limiting the ability to guide individualized therapy and detect emerging resistant patterns. Europe has nevertheless made important contribution through the development of a standardized definition and clinical practice guidelines, including the ERRTC criteria actualized in 2020, and recommendation from organizations such as ECMM, ERCIL, and ESMIC, of course. Recent initiatives have provided the largest assessment of mycological diagnostic capacity conducted to date, including 388 hospitals across 45 countries. This study demonstrates that 99% of participating centers have either on-site or outsourced access to microbiology laboratories, reflecting important structural availability across Europe. However, the analysis also revealed important geographical differences associated with economic resources and healthcare capacities. You can see this difference analyzing the availability to basic diagnostic methods, which is generally high, but recent data indicate that culture media are available in more than 99% of centers, microscopy in 97%, and antigen detection methods in 94%, but molecular techniques just in 85% is quite high, but it's not available in all the institutions that answer these questions. Although basic diagnostic tools are broadly available across Europe, access to more advanced mycological techniques remains strongly influenced by economic resources. Significant disparities are set according to national income levels. So, as you can see, in countries with lower GDP, the availability of specialized methods such as calcofluor, Malitov, Aspergillus PCR, or beta-glucan testing remains considerably limited. In contrast, high-income countries show substantially greater access to these technologies, with availability frequently exceeding 75% of the institution. These findings just reveal a persistent diagnostic gap across Europe and suggest that economic inequalities may directly affect the timely diagnosis and management of invasive fungal disease. Access to therapeutic drug monitoring also varied across Europe, particularly for voriconazole. TDM is essential to provide an adequate antifungal dose and reduce drug-related adverse events, and it is necessary if you treat the patient with voriconazole. But TDM availability was closely also related to the GDP of the country in which each of the institution was located. As you can see in this figure, countries with low GDP have less availability of TDM for voriconazole, that it is necessary for treat properly our patient with aspergillosis. Regarding therapy, current guidelines recommend triazole as first-line therapy for invasive aspergillosis caused by azole-susceptible Aspergillus fumigatus infections. Voriconazole remains a standard treatment option, although TDM is recommended, as previously said, after days of therapy. And isavuconazole has emerged as an alternative first-line agent with more favorable pharmacokinetic profile and less frequent need for routine TDM. In select situations, including those with suspected azole-resistant hepatic dysfunction, intolerance, or refractory disease, liposomal amphotericin B represent an important alternative treatment, and also maybe posaconazole in some specific scenario as salvage therapy. Combination antifungal therapies such as triazole or liposomal amphotericin B combined with echinocandin may be considered in careful selected patient, although we don't have evidence and clinical trial to have this kind of evidence to treat this patient in combination. But in some scenarios, as you can see after in my next screen, you can see where you can use combination. In parallel, antifungal susceptibility testing, therapeutic drug monitoring, and early assessment of treatment response remain essential components of optimal patient management. This is a real-life experience of isavuconazole reviewed in hematological patients, reviewing some kind of studies using isavuconazole as prophylaxis or treatment. You can understand that isavuconazole, with his better profile of secure, less interaction, is properly used in this stem cell transplant situation with a lot of immunosuppressed agents and risk of interaction, as is an alternative of posaconazole that has the best evidence of primary prophylaxis in hematology patient, high-risk hematology patient. But isavuconazole is an alternative when you can use posaconazole. Also, using treatment, you can see like rates of response like between 40% and 60%, more or less the same of voriconazole in the clinical trials. This is the screen that I said that when we use combination therapy, well, we probably recommend using combination therapy when you have a severe or disseminated disease, mixed infections, or kind of resistant or suspected resistance, also intensive immunosuppression, that when you can have the access to properly diagnostic methods, and of course when you have this drug-drug interaction of problems with PKPD of previously therapies, and probably in breakthrough or more active prophylaxis is very accurate use combination therapy than monotherapy. But new antifungal agents has emerged, such as fosmanogepix, ibrexafungerp, olorofim, operconazole, and risafungin, and is expanding the therapeutic pipeline against Aspergillus. These antifungals may offer activity against resistant and difficult to treat species, representing promising future alternatives for invasive aspergillosis management. Now we have more experience using with that in expanded uses of these drugs, but it's not yet commercialized, some of them, so we have to wait till we can use more widely in our institution. Antifungal stewardship programs have emerged as a key component in the management of invasive fungal disease, particularly in the context of increasing antifungal resistance and growing therapeutic complexity. Across Europe, stewardship initiatives commonly incorporate several elements, including appropriate antifungal selection, optimization of dosing strategies, and therapeutic drug monitoring, timely de-escalation or discontinuation of therapy, and implementation of diagnostic stewardship, prospective audit and feedback, and creating local prescribing guidelines, clinical education, and surveillance of antifungal use and resistant patterns. Importantly, successful stewardship programs rely on a multidisciplinary approach involving infectious disease specialists, microbiologists, pharmacists, hematologists, intensivists, everyone who treat and diagnose our patient with invasive aspergillosis. The goal extends beyond simply reducing antifungal use. Rather, stewardship aims to ensure that the right patient receives the right antifungal treatment at the right time. Future direction in invasive aspergillosis management across Europe increasingly focus on innovation and personalized care. Current initiative emphasize the implementation of standardized practices across countries and the adoption of One Health approach. Surveillance system for resistant patterns and integrating digital stewardship tools are also becoming priorities. Efforts have been directed toward expanding training to improve expertise in fungal disease. Emerging diagnostic strategies, including hazard approaches, artificial intelligence, and point-of-care fungal diagnostic, may also facilitate early and more accurate detection. So, to conclude my speak, this is some kind of brief messages. Like invasive aspergillosis, epidemiology in Europe is rapidly evolving beyond classical hematological patient. Early diagnosis remains the cornerstone of improved survival of a patient, but implementation gaps persist across Europe. So resistance is one of the defining challenges in modern aspergillosis management in Europe, and stewardship, diagnostic, and susceptibility to surveillance must be integrated in all the management of invasive aspergillosis. Collaboration across Europe has driven progress and remains essential for the future. But this is a resume. The European experience with invasive aspergillosis teaches us that progress depends not only on a better antifungals, but on faster diagnostic, smarter stewardship, resistant surveillance, and international collaboration. Thank you so much for your attention.
Thank you very much, Dr. Marina, for the excellent, insightful presentation. We will now move on to the Q&A session. Thank you to everyone who has submitted your questions in the chat and Q&A box. We will address as many questions as possible in the next 20 minutes. Okay, so the first question here is on when talking about azole resistance, is isavuconazole included? Question is open to any one of the speakers. Thank you.
Yeah, and comment. Yes, most of TR tandem repeat mutation of isolates shows high pinosol resistance, including isavuconazole.
Okay. We have one more question. Nurnabillah is asking, was antifungal susceptibility testing was done on Aspergillus fumigatus mold? These questions for Dr. Ümmü.
About my case, it's actually one of the limitation in Malaysia is that we don't do the antifungal susceptibility. In most hospital, we don't have actually for Aspergillus fumigatus. So in my case, we didn't do. And then if we suspected, so we use the antifungal is actually by faith. If we suspected, we need to send to our to the reference lab, Institute Medical Research.
Thank you.
I think another question for Dr. Umu. Were wound cultures taken before the plague appeared? This question is
No,
yeah, for you.
we didn't take any surveillance culture before that.
Dr. King is asking, this question is for Dr. Chua. And how to diagnose invasive pulmonary aspergillosis in a context where we don't have a specific diagnostic test as PCR or galactomannan?
Yeah, I think thanks. I think this is a very good question. I think based on observation and what I learned from it, it's like in order to, I mean, when we diagnose an invasive pulmonary aspergillosis, probably look at the EORTC criteria will be if you have a relevant host who have a very compatible clinical radiological imaging that suspicious puts you in suspicious of fungal infection or invasive aspergillosis, then probably the next thing you could do is like a bronchoscopy and then to get a BAL fluid and for culture. And there's positive culture. I mean, even without mycological evidence based on the criteria, you can still empirically start treatment for possible disease and probably send off those biomarker still if you have it to other labs and for confirmation. But otherwise, for me, because the mortality burden is high, if you are highly suspicious of an invasive aspergillosis based on the patient and CT findings like halo sign, pulmonary nodules with ground glass opacities, I would empirically start treatment first before waiting and not to wait for the biomarkers to be sent. Yeah, if that's not available. Yeah.
Thank you.
Here there is a question by Jesus Saavedra. Which would be the current role of isavuconazole versus voriconazole or posaconazole for the treatment or prophylaxis in high-risk hematological patients?
So the most evidence of using azoles in the prophylaxis of hematological patient is for posaconazole because it has a clinical trial demonstrating that. Not isavuconazole or voriconazole. And we use isavuconazole in our institution when we can't use posaconazole because of that, because the evidence is for posaconazole. But drug-drug interactions, toxicities of posaconazole, mainly hepatotoxicities, trends to use more isavuconazole in this context. But we have to be careful with the use of isavuconazole because we don't have this clinical trial, but our experience is good. We have breakthrough infection, but also with posaconazole. And the experience of our institution and other groups are similar It's an alternative, secure, and easy to use in this context of complexity in stem cell transplant or leukemia patient with target therapies. And the drug-drug interaction is a common situation with it's a challenge for hematologists and infectious disease physician in this context.
Thank you. Farah Mohammed is asking, will you use multiple culture positivities to aid your diagnosis? This question is for all speakers.
I think when you have like multiple culture positive and you have a patients that fits your clinical pictures, so I think it increase the possibility and the probable of the diagnosis, and it increase the sensitivity. So yeah, in a right setting, host factors and then clinical pictures, yeah, it will help you.
I think
I comment. Yeah.
nice. Yeah, and also Dr. Cha. Yes,
Yeah,
please.
no, I mean, just my comments. I think probably following in Afira's case, other than the positive culture for me, that push. I mean, the highly suspicious of aspergillosis will be the histopathological examination. I think if there's evidence of that fungal invasion, fungal hyphae invading the tissue, then I guess that is a proven disease for that in the right clinical setting. So I think rather than just culture alone, as I previously mentioned, if we are dealing with a patient who has a chronic a lung disease, and then as you know, aspergillosis is a very ubiquitous in the environment. Having a positive culture, even though persistent positive culture, but they don't have that right clinical context. Sometimes it could be just a colonization, but we have to probably look at case-to-case basis and interpret with other factors than just that culture alone. Yeah, that's just my comment. Yeah.
Thank you.
Okay, Dr. Umu, there's a question for you, I believe, was by E.J. Bakri. Was there any concurrent bacterial infection in the wound?
No, during the course of treatment, we just only give the patients voriconazole.
Okay.
Okay. This is another question. What's your opinion on combination therapy with amphotericin and azole, even though there are some data about possible antagonism? Dr. Marina?
Yes, I know this antagonism possible effect. In fact, these are in vitro studies. This is not like properly assessed in clinical situation. So maybe the combination therapy with azole and amphotericin B could be an option with breakthrough infection in where you suspect like Lamentospores infection or fusariosis or something like that, where high MIC of azole is a complex of management of patient. Probably using in aspergillosis is quite rare because if you use combination therapies because of some kind of resistant patterns, isolates or suspected, and breakthrough infection of non-fumigatus species, mixed infection, while mucormycosis could be addressed. But it's complex, this recommendation, but in some scenario, clinical situation could be used despite this antagonist in vitro study, because on clinical situation is not properly assessed, and could be an option in some scenarios, like fusariosis, for example, could be an option of using combination these two drugs, because of echinocandins is not active against mucorales or fusariosis. So this combination could be an option when you suspect non-aspergillus infections in breakthrough infections.
Thank you.
Okay, Blessing James has asked, what are your experiences with diagnostic methods used in diagnosing invasive aspergillosis in children, if any?
I don't have any experience with pediatric
Okay.
populations.
Same as Afra. Maybe Dr. Marina have any other input for this?
Not me neither. Me neither. I don't have experience treating pediatric population. It's true that we have a very good team of pediatric infective therapists. So we share information between them, and we treat. We try to discuss some complex scenarios of pediatric population between them, and they ask for clinical assessment, of course, of our laboratory, but specifically, I don't treat pediatric patient, and I don't have a huge experience like in adult situation.
Yeah, I mean,
Thank
just
you.
to add on a bit, based on my reading as well, I think certain biomarker, especially like the PD beta-glucan, actually they have like the cutoff are actually not suitable for pediatric population as well. So I think so we probably need to speak to the pediatrician when we suspect these kind of patients, and yeah, probably had a more multidisciplinary meetings to further discuss. But yeah, just the biomarkers as well, the cutoff might not be too that we use for adult might not be useful for pediatric population.
Thank you. Dr. Konstantinos is asking, do you have any comment about nebulized antifungals?
We have some kind of experience of nebulized amphotericin B in critical ill patients. We try to assess also the prophylaxis effect on kappa in some scenario, but we don't use as a routine treatment in our institution. I don't know if other in Spain or Europe are using widely this kind of strategy, but yeah, we try to use systemic antifungals more than nebulized. Maybe in the future with opiconazole as an alternative use of a nasal nebulized could be an option, but now with amphotericin B, I don't have much experience using that. But yeah, probably it could be an option in this scenario, combining systemic antifungals and nebulized for tracheal bronchitis and kappa, for example, or something like that, could be an option to treat this disease.
Thank you. Okay, next question. Hi, Dr. Afira. How long was your patient treated with antifungal? Apart from deep tissue mycosis, did he have any other dissemination, Dr. Afira?
It's a good question. But in my case, we treat the patient for 2 weeks. We don't have actually good data in terms of duration of treatment. Some said it's actually you can treat it for 6 weeks, but we are working in a low resource settings. So we monitor the galactomannan, and I think once the result negative and the surveillance culture is negative, at 2 weeks we already stopped the treatment. The patient doesn't have any dissemination, so we referred to ophthalmology, and he didn't have any eye involvement, and he was ventilated actually low setting, and he didn't have any lung involvement as well. Just a skin cutaneous manifestation only.
Thank you.
Yes, Dr. Forrest says that I work in a hospital which cannot do antifungal susceptibility tests, beta-D-galactomannan or beta-D-galactomannan or PCR. We depend on reference lab and asking how he asking how much does use us using RefLab delay your diagnosis. This question is outside of Europe. For outside of Europe.
I think so. I totally understand. Like when you work in a low resource settings, when you don't have any things, I think sometimes you have to use your clinical judgment. But then it's actually to have an access. And we should fight actually to have the access in our settings. But I totally understand it sometimes we use our clinical judgment. That's why we need to have a good diagnostic test so that we don't actually start patient on broad spectrum, antifungal, everything. So it's actually to find the balance is actually quite difficult. And I can totally understand that.
Okay, thank you. Next question by Anmol Singh. If a patient is already on antifungal prophylaxis in a cancer setting hospital and the clinician is suspecting invasive aspergillosis, BAL sample is not possible due to platelet count and serial serum galactomannan is coming negative, how should we proceed in such cases? Should we refer to only CT findings?
Yes, this is a problem that we had with this platelet count in hematologic patient. We try to perform always as when we can bronchoalveolar lavage fluid transfusion platelet before, and we perform this bronchoalveolar lavage fluid when we have more or less 40,000 platelet counts. But sometimes it's not possible, and we try to use the more than we had, the galactomannan, beta-glucan, CT scan, of course, or sputum culture, PCR in sputum, but it's a problem, and bronchoalveolar lavage fluid sometimes it's not possible. But if it's not possible, like the patient probably had high mortality if you don't treat it, probably you try to treat properly, despite you don't have these macrological results or confirmation. And we try to use properly therapy in this scenario.
Thank you.
Yeah, agreed. Yeah. I think in this case, like just to add on, it's a bit challenging when you had and in these settings when you couldn't do a lower respiratory tract sampling, and then serum galactomannan would be probably negative because of patient on more prophylaxis as well. So I think it's a bit challenging, and attempting to get a culture would be the next best thing, I think. And also in this situation as well, probably we have to consider whether a breakthrough infection with the more prophylaxis, and probably consider changing it to liposomal M4B, and while you're waiting for more investigation to be done if the patient is critically ill. Yeah, probably my opinion for this question.
Thank you. Another question for Dr. Ümmü. Why was the serum galactomannan being positive if the disease was only in the skin and the patient was not having neutropenia?
It's a good question, and to be frank, I'm not sure because a burn because the case that I illustrate just now is a burn patient. Even in our guidelines, most of the guidelines, burn patient was not included as the classical risk factors patients. So in my patients, because the clinical pictures, you have the clinical features of spores, and then you have a histopathological examination of infiltrate, like the branching hyphae, everything. And then you have a multiple, I think 2 to 3 is actually positive fungal culture. And I think the galactomannan is only adding on supportive for these patients. But the fungal blood, from the blood is actually negative. And I don't have any evidence of it's in the blood itself. So it's a difficult question. And I don't have much evidence on that. Maybe others expert knows this better.
Yeah, I think I agree with Dr. Alif answer. Like question whether you think that it could be positive. It could be due to a false positive galactomannan, and did we? Yeah, but yeah, I mean, you see on enteral nutrition or any other things. I know pip test, I mean, it's less commonly associated with false positive, but I think sometimes some beta-lactam antibiotics still can cause false positive. But again, yeah, they didn't consider a false positive galactomannan in this case, or just doesn't fit everything.
Okay, thank you. So one more question. Could there be any explanation for false positive galactomannan tests?
Yeah, I think yeah, just my comment, I probably have answered that. So yeah, there could be false positive, especially in enteral nutrition. And then I think historically they said using pip test can have a false positive. I think, but has been much more negligible at this modern era, and also using, I think, if I'm not mistaken, some plasma-like infusions or even intravenous immunoglobulin can cause false positive as well. So yeah, these are the other causes for false positive galactomannan.
Thank you.
Okay, I have one question just to ask you on the serial monitoring of galactomannan. How often do you send for the test for disease progression?
In our institution, we don't have this screening test as using galactomannan in high risk scenario like neutropenia or transplant disease. We use just in clinical scenario with symptoms when we suspect some kind of breakthrough infection in prophylaxis scenario or fungal infection in a patient in critically ill context. But we don't use in this screening test as previously guidelines recommended using that because of that, because of false positive or negative galactomannan test in prophylaxis or as my colleague says, factors that contribute to false positive. And we perform sometimes when the first galactomannan positive is diagnosed is positive, we perform this screening when we treat patient to see if galactomannan is decreased or not. Sometimes once per week or something like that, but just in this treatment scenario, when the first galactomannan diagnosis is positive, but not on screening when high-risk neutropenia or stem cell transplant without any kind of symptoms of fungal infection.
Okay, thank you.
Thank you very much. I would like to sincerely thank all our speakers for sharing their valuable expertise and perspectives. And I would like to thank all participants for joining us and for the engaging discussion. And I would like to mention that the next ethics webinar will take place on June 2nd and will focus on non-IV amphotericin B evidence, applications, and pharmacological rationale. We will be delighted to welcome you to this upcoming webinar as well. Thank you. Dr. Shalini, over to you.
Thank you, Prof. Yasmin. Thank you, speakers. Thank you, everyone.
Thank you. Bye.